Therapy, speech language therapy and myofunctional clinic here in Lawrence. And I'm so excited to introduce our presenters today. Jana Wallen is our myofunctional specialist. She's also a speech language pathologist over here.
I'm not saying everybody.
And Dr. Tim Harry, back in the back of the room here. I'm going to tell you a little bit about these guys and let them present and take it away. Jana received her bachelor and master's degree in speech language pathology from Lamar University in Vermont, Texas. And y'all will hear her Texas accent. She's not that strong, but it's awesome. She has over 27 years of clinical experience. Jana has grown a passion for pediatric feeding disorders, myofunctional disorders in both children and adults, and speech clarity interventions. Her specialized feeding and myofunctional trainings over the past 2 decades have helped Jana become a more well-rounded therapist, and this has translated to better care for her patients. She is ASHA, that's the American Speech Language Hearing Association, and CASHA, the Kansas organization member, as well as a member of the International Association of Orofacial Myology. And as speech pathologists say that, but Jana loves to learn. She enjoys sharing her passion and knowledge with others in the field. She has worked in a variety of settings, including hospitals, schools, home health, and now private practice at Sound Speech Therapy. And I can say that she has been instrumental in helping all of us as therapists grow at Sound Speech Therapy. I am looking at all of my patients with a different lens since Jana came in with this knowledge about orofacial myofunctional disorders. You know, I've been doing this for almost 20 years and I didn't know what I didn't know, but now I know. And I'm so excited for you guys to learn a little bit about it too. Dr. Tim Harry is a third-generation dentist who graduated from UMKC School of Dentistry. As a biological dentist, he aims to connect the dots between the mouth and the whole body health for his patients. His passion is identifying growth and developmental concerns for young children and collaborating with other practitioners to allow his patients to flourish into healthy adults. He also helps his adult patients thrive by harnessing the healing power of proper breathing, sleep, and real food. His holistic practice in Leawood, Kansas focuses on airway, TMJ, sleep, tongue-tie, orthodontics, and bio-rejuvenation dentistry. Also, I've been doing speech therapy all day, and sometimes I can't talk at the end of it. Health is rarely a straightforward path. In connecting his own dots, Dr. Tim experienced the very treatment he recommends to patients, including a tongue-tie release, surgery to help with nasal breathing, TMJ bite stabilization, myofunctional therapy, lip taping, and home sleep screenings. Solving his own dysfunction has led Dr. Tim on a path to be involved with great organizations and amazing mentors. He has over 14 years of TMJ and orthopedic skeletal stabilization training through the OBI Foundation for Bioaesthetic Dentistry and the Stewart Center for Minimally Invasive Dental Medicine. His training for orthodontics and skeletal expansion, including an airway orthodontic continuum with Dr. Mary Burns, DMD, and numerous years of highly specialized training for expansion devices. Dr. Tim completed one-on-one surgical training with Dr. Okay, you say it, Jana Zaghi, Dr. Zaghi. What's the first name?
Sarouche.
There you go. Sarouche, Dr. Sarouche Zaghi, MD, in functional tongue-tie releases, and is an affiliate office of the Breathe Institute. Dr. Harry serves as a member of the International Academy of Oral Medicine and Toxicology, the Kansas City chapter president of the American Academy of Physiological Medicine and Dentistry, and immediate past president of his local dental society in Kansas City. And he is a delegate to the Kansas Dental Association. So thank you so much for welcoming both of our presenters. We're going to start with Jana, and then Dr. Harry will finish it up. We will try to be fairly quick. Feel free to ask questions as we're going. Again, this is casual, and again, order drinks, get food, and thank you all for coming.
And after that bio, I am so glad I'm presenting first. Anyway, Dr. Harry, Dr. Tim has been so instrumental in my mentor in so many ways of working myofunctional therapy. And, you know, I kind of came upon this a couple ways because, as Kim said, we're kind of old people in our profession. You know, I have 27 years of experience. And we work with speech kids on speech clarity, right? And how many times have we worked and figured out, this kid isn't making progress. Why isn't he getting his R sound or his S sound? And it wasn't until I started really looking at my kids with a different lens that I was able to help them and get them to the next level. And also personally, my daughter is an adult. She's here in the class. She's had a myofunctional journey of her own, and that's also a huge passion of mine. So I just love it, and I'm just going to share some of the things that I'm working on with my patients and how we're doing things at Sound Speech Therapy, but I couldn't go forward without introducing these amazing women. Kimberly Williams, our steadfast leader, is amazing at Sound Speech Therapy, and she and I and these girls are building something super special here in Lawrence and with our occupational therapy and speech therapy. And so if it weren't for her support and these ladies by my side, I would not be here talking to you guys today, so thanks guys. So we're just going to kind of start off a little bit. I don't know if anyone is familiar with this book. I thought I had it, but this is an amazing resource that I use every single day, and it's by Christy Gatto. She's a speech pathologist, and basically this depiction of the orofacial complex and how complex it is, you know. And the O&D world, orofacial malofunctional disorders, isn't really new. I kind of pulled this definition back 40 years ago that Hansen put in, and it's really been around for a while, but I think it's kind of getting some traction. I think people are hearing more about airway and tongue tie and its impact on craniofacial development. I think that's where, as a speech pathologist, how can I help my kids with their feeding and swallowing? And this is a big piece of that. And so with myofunctional therapy, of course, I tell my patients it's physical therapy from the neck up. You know, we're working on these muscles that have dysfunction so that they create better function, right? And so that's what we're doing in therapy every day. And I talk about connecting the dots, and I know that Dr. Harry talks a lot about this on his website, but it is about connecting the dots, and it was for me because even 10 years ago, I never thought about asking my patients about their breathing, ever, as a speech pathologist. I never thought that that was important. But I'm realizing that when I go through and I'm evaluating my patients, it's all about the orofacial complex, and all of these things are what I'm looking at during my evaluation. And I'm critically kind of thinking, how are these impacting their form and function? And so another wonderful person, if you ever have a chance to read about her or her webinars, is Lyndon Donofrio. She's another speech pathologist who is an amazing guru in our field and kind of my hero. And she really talks about, and is really helping us as speech pathologists learn more about oral function and how it impacts breathing, swallowing, and speech. And she always asks this question, how does oral dysfunction escalate into malocclusion, overall development of breathing, swallowing, and speech, and craniofacial development? So these are my points that I want you to ponder today. Okay, so I've thought of some of these on my own, but some of them have been through my readings. But most kids, most infants are born beautiful. They come out of the womb, they have normal craniofacial development. We know that. But we know that changes in their oral function create changes in their facial development. And so when I have a little boy who comes to me at 3 years old because his parents can't understand what he's saying and they want a speech pathologist, and he walks into my office and has his jaw down and he's like this, something's happened between maybe a normal birth into the 3-year-old time where he looks different. Something's happened with his oral function. And so I think everyone in this room who works with patients, and if you're in patient's mouth, I think we really have to think about oral function and how it impacts the structure of the patient's mouth. And I think that that's what I'm trying to look at with my patients when I'm looking at occlusion and looking at how their teeth are coming together, the open bites, the cross bites, things like that. What is causing that? And that's kind of where always my questioning attitude is coming in when I try to look at my patients. I do think that the need for some orthodontics may be a symptom of an underlying oral myofunctional disorder. And I do think that we know that OMDs are sometimes a marker for obstructive sleep apnea and breathing disorders. So that's a big one. But the biggest one I want to say is I think they're preventable, that it takes a village and it takes us really identifying them very early, and early detection is key. So some things that I look at when I'm evaluating my kids is I'm always asking them about feeding, right? We know breast is best, obviously, and the breastfeeding experience for these infants is the best oral motor workout they can get. It sets the stage for really good craniofacial development. The longer a child is breastfed, the less likely they're going to have malocclusions. They're going to have big white palates.
Is there a point where there's a diminishing return, or is it linear that like at a year or a year and a half, is it still decreasing malocclusion? Does that make sense?
The shorter time that they breastfeed, you mean?
Right, I'm saying, that they say, 6 months to a year.
12 months is kind of the recommended time that,
Does after that provide reduced malocclusion?
I think absolutely.
Really?
I think that the more that we provide that stimulation to the palate in some way, the more wider palate we're going to have. And I think that that's not always possible for our babies. We know we have tongue restrictions. We know we have tethered oral tissues that limit babies from being successful with this process. But I do think that that's a big impact on what we're seeing in craniofacial development. Another thing that we're looking at for craniofacial development, of course, is airway obstruction. We know that airway is everything, and obstructions can lead to changes in the course of the craniofacial development. We have lots of etiologies for airway obstructions. Tonsils, adenoids, sinuses, terminates, you name it, allergies. But as a speech pathologist, I'm now asking those questions with my children and even my adults. How's your airway? What's going on? Why are you mouth breathing? Why do you have your mouth open all the time? Let's think about that. Moving on. This is a big one. A lot of you guys are here because you're interested in tethered oral tissue, and we call them TOTS in the speech therapy world. I don't know whatever other people, that's kind of our nickname for them, but I'm seeing more and more tethered oral tissues, but I think I'm understanding how to recognize it than I was 10 years ago. And I think that's a big piece of it. 10 years ago, if I had the kid that came in like this, the 2 or 3-year-old that I'm talking about, I would have never even thought about tethered oral tissue. I was taught in grad school if they could stick their tongue out, they were fine. But that's not the case. We're learning more and more about tethered oral tissue. And, we have so many professionals in here who are so in tune with fascia and the release of fascia, and our craniosacral therapists and our chiropractors, and so many people who can be part of a multidisciplinary team to help babies, young children, and adults when they have tethered oral tissue. We also know that tongue ties are correlated with narrow palates and other malocclusions, and obviously they impact feeding, swallowing, and speech. And a big piece of this, and this is my experience, is that most of the kids, in the cases that you're going to see today, the parents will tell you they've been breastfed fine, no problems. But sometimes when we see red flags is when those babies transition to solids, or when they start trying to chew harder foods. We start seeing this kind of rear its ugly head in feeding. And so I'm going to talk a little bit more about that, but I think that it's real important for our babies who are getting these frenectomies to keep our pulse on them, because I think sometimes babies get a frenectomy and they're just fine and they don't need any other interventions, but we want to make sure that we're not losing sight of maybe a potential oral dysfunction that could lead to something down the road. Okay, I just have a question for this group. With COVID numbers and everything happening with COVID and the mask wearing, does anyone feel, and I know I've talked to some provider here, I can't remember, that we've had an increase in mouth breathers? Anyone with masks, with kiddos? I'm going to say some anecdotal observations. I feel like I'm wondering if there's going to be some data that indicates that we have more mouth breathers because of the masks. And we know that mouth breathing is not optimal. We want nasal breathing. All children, all adults need to be nasally breathing. And when we have children, or anyone who comes in our office or to the doctor's office and they're mouth breathers, we need to be asking why. Mouth breathing encourages, nasal breathing activates the growth of the facial bones, the occipital and nasal joints. Obviously, it keeps out bacteria. And we know, especially in the clinic, our mouth breathers are sick a lot. They call in and they cancel therapy because they're just sick a lot. It definitely changes the way the face is shaped, the craniofacial development. And it's a risk for OSA and sleep disorder breathing. So I always give this picture to families and say, go, before you come to your evaluation with me, take some pictures of your kid while they're sleeping. Listen to them. You know, take some video of them snoring so we kind of know what their nighttime breathing is like. So I'll have right there. All right. Oral rest postures. Does everyone have their tongue on their spot?
I do, because you always remind me to have it done last night.
So, impact of oral rest postures. It is essential for craniofacial development. Babies who come out with normal craniofacial development have their tongue up on their palate. That is normal. They're breathing through their nose, tongue up on their palate, and their lips are closed. If you see a baby who has their mouth open, that is not normal. Okay? If you see their tongue at a low resting position, that is not normal. If you see an adult with a low resting tongue position, that is not normal. Okay? So you may have an aunt or an uncle or a friend or a child who may be puffed by, who has a frontal lisp. Okay? That is a low resting tongue position. Okay? That's not normal. That's not normal. We want to understand why the tongue is low resting. Is there a tether? Is there not enough room on the palate for the tongue to move up? What's going on with the tongue to if everything in the mouth is working correctly, we should not have speech problems. Okay? And so when we have these kids who have these 10-year-olds who come in with R deviations and they can't say their R's, what's going on with the 10-year-old who still can't say his R? Something's going on with their oral function. Okay? Let's see. I tell my patients all this, what is your tongue doing when your tongue is doing nothing? Is it up on the spot, lips closed, nasal breathing? And where the tongue rests is where the tongue speaks. So if your tongue is resting low in your mouth, you're going to hear frontal lift and lateral lift, and you're going to sound like that. So we want to figure out the why behind all that. You know, I love, people talk about myofunctional therapy with adults, but let me tell you, I'm teaching my 3-year-olds at work where to put their tongue. So we talk about Tucker the tongue. Where does Tucker go? You know, I'm teaching 3-year-olds where to put their tongue. And I think it's really important that we have to start early with these kids so they figure out, and it's amazing. They learn quicker than the adults. So we really make it fun. We have games. We really try to make it interactive so the kids can participate in the adults. Here we go. Oh, great depiction by Boise Speech and Hearing. Who do you want to look like? Right? Who do you want to look like? You want to look like upstairs, right? Yeah, upstairs. Okay. Oral habits. Yes, our thumb suckers. We have a ton of thumb suckers that come to the clinic. And the #1 goal for myofunctional therapy is getting rid of habits. And so a lot of the orthodontists and dentists will see thumb suckers in your chairs. And we work on getting those eliminated. And I have a great program that I use with my patients, and it takes about 4 weeks. And I'll tell you, I have about a 90% success rate. Not everyone, but 90% because we really do it in a really positive way. And here's little Charlotte with her party. We have a thumbs up party. It's a big deal at Sound Speech when you stop sucking your thumb, because we know they're empowered, and then we can move to the next step to retain good oral posture, good nasal breathing, good swallowing skills, and good speech skills. All right, let's see. And then of course you guys know OMDs impact our swallowing. The biggest one that you guys who are working in mouths are going to see your tongue thrust, right? We're going to see an anterior tongue thrust of the mouth during the swallow. And usually that's because they don't have a good lingual-palatal relationship. They can't get their tongue up on the palate because maybe it's tethered, maybe they don't have enough tongue space. Getting that tongue up in the palate to create an intraoral seal to swallow correctly is essential. So what they'll do is they'll anchor their tongue on their teeth and create the intraoral seal. And that's what creates the swallow. So we we take these patients through a step-by-step program and teach them, break down the swallow very incrementally. Start with holding the water in their mouth with the trap, with the lingual palatal seal, swallowing carefully. We just do it very incrementally and retrain and re-educate the muscles. And then once we're done, we have a big party and everybody gets to bring McDonald's speech and we have a big meal when they get done with their swallowing therapy. As speech therapist, a tongue thrust is a type of oral dysphagia. Okay, speech therapists work with swallowing, and a tongue thrust is an oral dysphagia. All right, and so being able to also work with chewing and swallowing, we're noticing that our OMD kids are picky eaters. Why are they picky eaters? They don't have the masseter and jaw muscle skills to chew hard foods. So they end up being on the chicken nugget diet. Chicken nugget, french fries, mac and cheese, right? They get themselves into food jags because they're easier to chew and digest. There's less bite force that they have to manipulate and masticate the bolus. So then they end up sometimes getting into really feeding disorders. You know, I've got some patients that eat 4 foods, right, or in the first percentile in weight because of their myofunctional disorder. So it's really important as we look at these kids, early intervention is trying to figure out what's going on early so we can provide some support to the families.
I have a question. Is that why they're trying to do more of less actual baby food and more of the baby-led weaning?
Yeah. I absolutely love baby-led weaning. I think for some kids who have severe myofunctional disorders, sometimes that's a little overwhelming. And we have to remember what system they're made with. You know, if they have completely flaccid muscles and anterior carriage of their tongue, they may be at a risk for chewing and choking. We have to take those babies sometimes a little bit, who have severe OMDs, a little bit of modification. I love baby-led weaning though. It's great. It's wonderful. I wish I would have done it for my own kids. But I think that's a big piece of that, yes. Okay, I'm just going to go through these real quickly. We've talked about a lot of them. You know, when I'm evaluating children who are birth to 3, I'm looking at all of these things, and I'm doing more of a feeding evaluation because we can't really, myofunctional is more, let's do this exercise 20 times, we're 20 times, 3 times a day. Giving that, let's do a tongue click as an example. So we can't expect a 3-year-old to do that, right? But we still know that babies and young children have OMDs. So we're looking at it with a little bit different of lens, trying to see how we can support the families, trying to make our referrals the way we need to. And the big thing that I do as a speech pathologist is I'm always looking at communication. Because if these kids are tongue-tied or have an OMD and they're not babbling, and they're not using their words, and they're 1-year-old or 18 months and they're not communicating yet, that's a big issue for us as speech pathologists. That's what we see. So I'm always, always, always evaluating communication, right, when I see our kids. As we move into the older kids, all of these symptoms overlap. But one thing that you'll see a little bit different is we'll see more daytime and nighttime breathing issues. Open mouth posturing, audible breathing, not sleeping through the night, wetting the bed. All of those things can be symptoms of an OMD. And then again, those stinking speech sound misarticulations, right? Speech sound, I'm going to give you guys a little staggering percentage, and some of the SLPs in here will be shocked by this. 81% of the speech sound disorders that children have an underlying myofunctional component. So we as speech therapists who are treating the speech sound disorders need to remember that. There's a big part of myofunctional disorder that is around speech sound errors. And then as we get older to adults, same symptoms, but we end up seeing a lot of bruxing and TMJ, like my daughter over there in the corner, who has a tongue tie and a narrow palate and now has some TMJ issues that we're kind of having to factor through, right? And then this is the 12-year-olds who come in, or 11-year-olds who still have a frontal lisp, or an R deviation, wabbit, still says wabbit for rabbit, and that's not normal. Why can that kid who's been in speech therapy for 5 years not say his R sound? because he doesn't have posterior lift of his tongue. He can't get the lateral sides of his tongue up. So that's a big deal. So obviously the functional impact of all this is huge. It goes across so many domains. And when we're doing our functional evaluation, our myofunctional evaluation, we're trying to see the implications on all of the function. And that's why you guys are all here, because no one can do this by themselves, you know? And so when I evaluate a kid, and let's go back to my 3-year-old friend who comes into the clinic and he's like, and mom says, I don't understand a word he says. Well, I'm sure you don't, right? He has terrible oral posture, and his tongue is hanging out of his mouth, and he can't breathe. So I'm referring to ENT, and then I'm referring maybe to pediatric dental for a tongue-tie, assessment. So we're all kind of working together to see how we can build a multidisciplinary team for these patients, and I think that that is why we're all here and learning from each other. So it is an integrative medicine approach. I always say let's be etiology focused instead of symptom focused. So yeah, this kiddo has a tongue tie, a tongue thrust swallow. You see it in the dental chair. He's got a tongue thrust swallow. Why does he have a tongue thrust swallow? Ask the questions why. What is causing this child to be a tongue thruster? Okay? And that's where the myofunctional evaluation comes in. Because we look at things from a functional perspective. We watch them eat. We watch them talk. We do functional evaluations with their tongue and all of their oral complex to try to find out the why. Now, is it always easy? No. Sometimes I don't know. Sometimes I have to rely on other professionals to help me because sometimes they're complicated and tricky. We know that the incidence and occurrence and the diagnosis occurs across varying times, so the timing of intervention varies. So I may see a kid who has a tongue tie, but he has a 29 millimeter palate. That's concerning for me to release a tongue with a 29 millimeter palate. Where's the tongue going to house? Where's it going to go? It's trying to put an 8-person sectional couch in a 100 square foot apartment. You can't do it. So we got to figure out how do we expand the palate to give it more space. How do we work with orthodontia to help these kids get more space so that they can fit their tongue? And let's work on the root cause.
Well,
Yes.
as far as root cause, does anybody look deeper as far as root cause of a high palate?
Well, yeah, I'm looking at, because we are all born, unless we have a tongue tie, we should be all born with nice large palates, because our tongue naturally is our natural palate expander. Unless that child at 4 weeks of embryonic development develops a fascia tension with a tongue tie, that tongue will stay down during embryonic development. So our babies who have a tongue tie will be delivered with a high palate. And
Yes.
so I do believe that tissue restrictions, good question, is a big piece of high and narrow palates, as is airway issues.
Yeah, it's been my clinical experience that if we're not assessing the cranial dura, which is why I'm a craniosacral therapist,
Absolutely.
which is actually the root cause of a high palate, displaced temporal bone, which causes TMJ. We can do all of these interventions as far as, revisions and whatnot, but we're not actually, we can go deeper
Absolutely.
than that. It doesn't get any deeper than the cranial dura.
And I like that because I really think that when we're talking about building this multidisciplinary team, I think it's critical for when we have tensions or restrictions within the body that we pull in our body workers and our craniosacral therapists. We have to, because we can't move forward if we don't have that piece of the puzzle. Absolutely. My tongue ties assessment, I use Zoggy. It's what I use for my tongue ties assessment. Essentially, we ask the patient to open their mouth as wide as they can, and we measure that. And then we ask them for the tongue range of motion, tongue to incisive papilla, and we measure that. We get a ratio. And then we measure the posterior tongue mobility by lingual palatal section. And then we provide a ratio for that. Again, it's not a perfect science, but it gives me something to kind of quantify to validate my functional assessment. And always my goals of myofunctional therapy are these 5 things. We want to give them exercises to enhance nasal breathing, lip seal, tongue position, swallow patterns, and of course, correct speech productions. Because at the end of the day, many of our patients aren't coming to us because they've been referred by their dentist or orthodontist. They're coming to us because they can't understand their kid's speech. And then we find out that there's an underlying myofunctional disorder. So we're re-educating and retraining the muscles. You know, myo, like anything, is not a cookbook. It's every patient is different and every dysfunction is different. So we try to cater and look at everyone's program that meets their needs. And I try to choose exercises that target specific muscle groups. And the biggest, hardest thing for me too, and everyone who does myo will say, you know, we sometimes skip to point D before we've mastered point A. So it's knowing when to move forward with exercises and knowing when to move back, because that's kind of a big piece of that. So I just have a few pictures to show you to end my part, and then Dr. Harry's going to come up. And then we're going to share a couple of cases that we worked on together. So I always say a picture is worth 1,000 words in our world. And poor Napoleon, the best quintessential model of myo, right? Big open mouth posture, just, and even in the movie he was nasal, you know, he just had this terrible, you know. And so I always tell especially my older kids, do you want to look like this guy? No. So, you know, and it's not all about aesthetics. A big piece of it is aesthetics. But it's always about function and becoming healthier and giving these patients the tools they need to become healthier. And these are just some great patients of mine who said, yes, I could use them on my board. But you can start seeing some patterns here of things that I'm looking at facially when I look at kids who have chickmunk cheeks. Here's a little tongue-tied boy who came to me, had no idea he has a tongue tie. Has feeding issues, can't hardly eat anything above a puree consistency, right? So we've got a boy here who's got airway issues. When I see kiddos who have grinded their teeth and have venous pooling, that's airway, tonsils, adenoids. We've got Harper over here, she's a sweetheart. So we just had, here's one of a little tongue tie here, you can see the retracted jaw. So we're looking at so many areas when we look at myofunctional disorders. And yeah, it takes a village. So thank you all for coming and thank you for listening. And Dr. Harry, you're up.
You guys can take this time to get some appetizers if
They're
you
bringing
want.
more plates, so.
Okay.
So just
That was so good.
Snap, you want to make this small ball. Get to go for seconds. They're grabbing.
I know it goes till 7, so we'll keep going. Thank you, Janet. That was wonderful. That was full of great info, and we'll keep the theme of connecting the dots with all this. So, to take Janet's info and just put a little different level on it from dental perspective and things that you can see looking inside the mouth, the face, little practical things that you can take back, and once you start to see it, and you see it on each person, kid, most every kid now, like some form of something, because it's more genetic. We're so far removed from the ancestors with the big jaws and things. And they've done research showing that you take anybody from, say, an indigenous culture, within 3 generations of a modern American diet, they have over 90% change within the skeletal volume of the face. So it happens fast. And so thanks to everybody at Sound Speech. This is wonderful up here. Good night, thank you, Kim. My journey is, as I said, like, done a lot of these myself with my dad in the middle. So he's been one of my mentors long term with, when I was in dental school, I was kind of lucky to tag along to some things he was doing with TMJ, occlusion, how the teeth fit together. And that started my process, and then over the years you realize, okay, well, most adults that have jaw dysfunction are really airway patients. And then you start to develop these trends and see things with each adult and person and start to take it to, well, they're there in that way for a reason, and so why don't we take the kids that you know and see these things, and can we help the kids and prevent them from becoming those adults that need a lot of dental work, root canals, crowns, TMJ, sleep apnea, you name it, and let's try to fix and save them. The adults you can try to backtrack, it's much harder. The kids you can just harness their own, you know, biological growth and move them in the right direction. So that's what this whole thing will be, is looking at, can we identify, and that's what Jana's job is, can we identify factors and things that are going on that are inhibitory to our growth and help remove them, and then put positive stimuli in place and get the growth back on track. So that's what I've known for myself. I mean, all this happened when I was an adult. With that, so I mean, when I did my training with Dr. Zagi, I mean, he did something with my nose to help me breathe. He's done my tongue tie release. My dad helped me with some TMJ issues and things. So when you kind of live it, you get a little more appreciation of it. So this is one of the best things I did. As far as like the tongue tie and myo, I feel like with Dr. Zagi and some of the things that he's doing, he's actually taking research more for the older kids. Like a lot of that research is validated 12 and up, but the younger kids, I mean, it's still anecdotal, but you know, you take all those principles, and you know, the thing is, with all the babies and young kids I see, that you hear it time and time again from pediatricians and ENTs and you know, other families and things that, you know, tongue ties are real, fight through it, it's not an issue, they'll outgrow it, which is really not a lot of truth in any of it and stuff. And part of it is the research is kind of all over the map. You know, you have something, a 1 grading scale where you talk about like a 1 is not so bad, and then this one, a 1's bad. And so there's a lot of confusion, and it's trying to distill that confusion down and try to make it a little more level playing field to talk about. You know, and that's what Jana showed, and you know, the grading skills that you have for older kids and adults, that make it much more streamlined and easier to talk about. And so a lot of the research and things that are out there from TMJ, tongue tie, how things are coordinated, on to sleep and breathing and growth with kids, and this is all done by them. And so it's a lot of new and exciting stuff, but most of the stuff that they're talking about though is actually not new. I mean, it's been in the literature for, you know, decades. It's just now coming to the surface because more people are talking about it and want to get involved in it, you know, especially for moms, you know, with all that stuff. So I was like, well, why are tongue ties so overdiagnosed now? So they're really not, just people are getting back to treating the issue. You know, in the literature, there used to be babies were born, midwives with the tongue, cut the tongue. You know, because there were no bottles, and a bottle's a medical device. And so then it became, we'll just give them a bottle. You know, mom's like, I don't want to do that now. Like, so let's get them back in the right direction with that. So some objectives, Jana's already hit on a lot of these things, but you know, what's going on, why are they there, how to identify them, how we can all work together to help with a lot of that stuff. So like this, and that's the theme of the night, collaboration, right? So, you know, if you want to do it, you can do it, but if you want a better treatment, find a team and a good team to work with that. So you got your sound speech team, you know, and one of the biggest things, especially like if you're taking it in an office setting and trying to implement things, you have to have your team on board. Everybody's got to speak the same language and have the same goals. But then also have other therapists that understand it, you know, and identify it as well to go forward with that, especially if you're thinking about myo and tongue ties and airway and that stuff, that is fine. There's a lot of different types of therapists that can help. You know, for me, if I'm talking to like a mom or a parent, find the ones that though are familiar with the things that you want. You know, tongue tie, airway, there's a lot of people that may address it, but if they're not getting down to, like you mentioned, like some kind of root cause of a high palate, then, you know, it may not take you very far. So in 2017, the American Dental Association came out with a white paper that said, within all dental offices, everybody should screen for sleep disordered breathing or sleep apnea. I mean, you can just look in a mouth nowadays and you see signs that something's going on. Very easy to spot. And so, you know, for most people that are not trained looking in the mouth, you know, outside of the speech therapist and stuff, that you can, kid and adult, I mean, it's so easy to see certain signs. We can go over some of that. And then in 2002, the American Academy of Pediatrics had a questionnaire that said all physicians should ask, like, parents, like, does your child snore? They did a follow-up study, and they found like less than 10% ever asked the question. They said, well, why? And they said, well, if the parent says yes, I don't know what to say. Well, we know why they're snoring, so I just don't ask it, because I don't know. And so I mean, it's not new, like, but they know, like, if it's doing it, they're like, well, they're going to outgrow it. But there's lots of literature that says if a child snores and grinds their teeth, they don't outgrow it, unless you take the symptom away and the root cause. So, so when you screen, what questions should you ask? When a problem's there, do you know how to answer it, how to address it? If you don't, who are the right people that are going to help you? So find those people that will be on your team. What's the root cause? There are plenty of things you can do to just patch and repair, especially in dentistry, what we do. But can we get to those underlying health things so it's actually true health versus just managing something that's going on? That's what our health system likes, is chronic stuff, versus acute. But and this goes back to 1912. In the medical journal, where it talks about, as far as dental, talking about taking out teeth. You're not doing anything better for them, but you're not addressing what it is. And the father of orthodontics, they're even talking about early palatal expansion in 1912 with that, to where deal with the skeleton, if you take tonsil adenoids out. So it's been around forever. It's starting to creep back up to the surface, but within this, you have your orthodontist, ENT, all people. So who's on your team? And it's a lot of people. Like sometimes the kids may see one of all of us, and you're just kind of working through things with that. So going from 1912 to, this one came out a couple weeks ago, but saying you can take out tonsil adenoids, but it still may not be the only thing. And so, what it says, a multi-pronged comprehensive approach. So find that team, get the people, maybe more than one thing. So especially with the kids when they're growing, you could have a kid come in and they could be 3 and you start the process, tell the parents this could be a 10-year journey. It's one step at a time. You're doing one thing, then the next, and the next, and the next. And it's always a continuum. You just always put one foot forward, but do the right thing with that. So I like to talk about with our pillars of health that it's always, this is the myo part of it, right? If you can teach somebody, especially kids, you talked with the babies, for them to feed, they have to breathe out their nose. That if you have your lips together, tongue up, eye added in, teeth not clenched, and the jaw joints in the right position. So if we can achieve those things, it's good function, good balance, good health with that, because you see a lot of kids already where the teeth are always together, outside of those things, and the jaw's not already lined up. So it's looking how do we put all that together, especially just for looking at the world up here. So the why with all this, I'm sure a lot of people are already familiar, but there's wonderful books, wonderful resources now that get into, we used to look like this with no orthodontics. Now you see this all the time, and it's, what's happened with that.
That guy got eaten by a dinosaur.
Wow. Natural selection. But you see, that's, so let's, figuring some of those things out. But no, there's so much literature and research on kind of what's going on behind it. And this goes back to actually a dentist in the 1930s. People may have heard of Weston Price, but as a dentist, the 1930s traveled the world and found similarities with all these cultures that he came across in all different continents. All had broad faces, wide arches, didn't need to see a dentist, had no orthodontics done, didn't have to have wisdom teeth taken out. What's going on? And so he found it with his research that they were eating the food that was growing in their backyard, and that was the biggest thing. But then his mystery ingredients that he found, like raw fat soluble vitamins, like if you're healthy vitamin D, especially K2, vitamin E, A, and all those things, then the jaw's going to grow. Chewing, they were all breastfed, they chewed from an early age, or baby-led weaning, give kids the right things to chew. Think about all this at weed. Chewing will lead to this. Muscle contraction, pressure stimulates bone, stimulates growth, same as the tongue going up. What that, he didn't know all that at the time, he just, hey, they all have these things in common, and a lot of the research has since come out and validated all that was found in the 30s and stuff. And so, now the Weston Price Foundation is all over the place with all kinds of health things and natural stuff. But That's the biggest thing, that they've realized over the years, that the epigenetics is the big part of it, to where we all have the same genes. The human genome has been mapped where we'll take it that, we could be born with certain genes, but it's just a blueprint. So what we do affects how the genes are expressed. You can eat McDonald's every day versus salad all day, and things are going to happen differently. It's the same thing with the growth. Put the positive stimuli back, you're putting the positive stimuli back on the DNA in the growth and giving the blueprint, for the direction of the growth with everything. It can even be done in adults, so you can still reverse and, put them back to it, but everything goes back to just the natural ingredients that our ancestors had for generations that we've, in a couple hundred years have gone so divergent from. So most of all of our health is just modern problems.
I would just like to add to that list that it's stress also in our environment that we're seeing. Increases tension in the body, but that then increases tension in the dural membrane system, which then affects our spinal and cranial bone alignment, which is our oral alignment.
Yeah.
And they do not have the stresses. I mean, they had like a saber-toothed tiger that did.
If you had two days this long, life would be easier, right? But another thing genetically that it boils down to, and this is where the speech comes into play, I think this is close, like one of my favorite research ones, but the reason we have sleep apnea, like we're the only mammal on the planet that breathes out of our mouth at nighttime during the day. They talk about, outside of like the bulldogs, right? That the sleep apnea is unique to humans because we speak. So, as it says right here, natural selection, the pressure for speech and language was so strong that won out because it progressed the human species, but what lost was the size of our face. The voice box descended down, the tongue went with it, so the tongue can drop in to the airway. Like all the other mammals, when they look at it, the airway's protected because the voice box isn't down. Even on a baby, for a baby's health and safety, there's protection from the tongue going to the airway, which is natural. As they get older, that descends down and stuff. And so just showing that, for us as humans, our brains have gotten big, but everything else has gotten small, and that's the byproduct of all these other things. So it is always multifactorial, right? That you hear so much like it's the tongue, it's the tongue, it's the tongue, it's soft tissue. Those things are there, but they say maybe 7-8% of the population actually has an actual tongue tie. That may be the one that you see to the tip of the tongue or not. So that's why it can be deceiving at times too. But so many other things, within our life. Like you mentioned, stress, chronic disease, things that are there. They just all add up. It's just like slow little cuts that just keep adding up, layer on one thing after the next with that. But that's what you have to look for. Like the thing I hear the most from parents, especially on infants, they come in, it's like, I don't really want to do this much. I'm kind of like borderline, should we do it or not? And just tell me like these things won't happen down the road. Like I can't. Outside the one that goes to the tip of the tongue, but even then you can't, like we can assume, right? But it's something to where, there are so many other things at play from the chewing to the lifestyle to the diet that there can be other things that play a role into why there could be speech dysfunction, crowding of the teeth and things. It doesn't always have to be just a tongue tie, but it can be one component. And so it's like, I can't like say you have to just because like they will have a speech problem if you don't do it like on a 3-month-old, but there's a likelihood, so it's trying to balance the pros and cons and really always give them, a choice and try to help identify, the research and what's going on. Jane already showed this, but the modern smile that we all see, all too well. You look at most of our faces, like mine included, like they're long and narrow, like a narrow nose, a small mouth, with all that. So the reason why some of this happens, I think this is pretty cool. Like if you ever want just tons of research on, especially pediatric sleep apnea or adults, just look up this Christian Humano. He's the one who basically coined the term sleep apnea at Stanford in the 70s with that. But this whole thing, is saying that it's not the inflammation and the stress and things that trigger the small jaw. It's vice versa. It's the small jaw and the small skeleton that triggers all those other things with that. So if you get back into the mouth breathing and the open mouth posture, the main thing that happens is, if we're looking over here, if the tongue is sitting right there, the the tongue is pushing up. It's holding the growth and the skeleton in the right position. If the tongue is down, if you ever see someone with a hump on the nose, where it comes from, it's muscle pressure, it's negative pressure from how the face is growing, how the airway is. So if the mouth is open, everything is rotated clockwise backwards. The chin becomes recessed, the face rotates down, you get the gummy smile, the long face with that. So basically it all comes back to, it starts with the skeleton, like you said, with that. And then all these other things can be layered into it with that. And like they mentioned, it's multifactorial when you think of sleep apnea, tonsil adenoids, and those things where, 93% of kids with sleep apnea have these facial structural changes. You can just look at the face and sense somebody's struggling. You can look at the size of the face, the eyes, the size of the mouth, and know that, and kind of assume there may be an issue, and then say, well, let's just dig a little deeper. What data do we need to get to try to figure it out? And most of the time, you don't even need a sleep test, especially on kids under 14. As Jan mentioned, just take a video. If you're sending a kid to an ENT, take a video of them sleeping, take a video of their breathing, their head arched back in the car seat, the mouth open, the snoring, all those things. That alone is diagnostic now of sleep apnea. And most of the time, if you see any of that, you just look in the mouth and the tonsils are big. Then you just have to fight with mom and say, go big now. But again, with this, it's like you take the Guilleminault hypothesis, where it starts with skeleton, where you could have abnormal growth that could lead to mouth breathing, and so on. And then so it's going back to the whole thing of where in the chain can you break the cycle? How do we identify what's going on? The earlier the better. Now, let's say a 5-year-old kid, especially female, like the jaw's almost 80% developed already. And so that's the trend. Like the earlier you start, the more impact you're going to have, even if it's orthodontic work or just therapy. It's always meeting the kid where they're at within the scope of behavior and when they're on this thing. And Dr. Zai's taken it because he did his sleep fellowship at Stanford with Dr. Guilleminault before he passed away, and layered in the tongue tie with that. So, if you see the low tongue tone, mouth breathing, noisy breathing, snoring, those things, that's why they say it's not benign. Like if you're snoring on a kid or heavy labor mouth breathing, don't just say it's kind of cute and move on, because it probably will progress over time to those things. It's all on a spectrum. Like where can we, stop that? The same thing, like, where does the first domino fall? Recognizing it early and starting to help. If you leave a 4-year-old in a CrossFit like that, what happens to them? You can already fix it on a 4-year-old and get it back with that. So you just redirected the growth. So I like to think of it as you're not expanding, you're just redirecting the growth back to what it should be, back to where biology should have it at that age and that time, and then you're just putting them back on a much better path. So you can take things in, and dental, I always talk about kids because it's my passion is trying to help them figure that thing out. But the Breathe Institute has things coming out with now trying to correlate all these things and give the physicians the research that want the data like here. But talking about sleep bruxism, grinding your teeth, how does that relate to tonsil adenoids, how does it relate to growth? But basically what the research shows, especially for in dentistry, that bruxing your teeth at nighttime is just a micro-arousal, where if you do a sleep study and you find someone grinds their teeth, it's always the body's getting into a sympathetic tone in fight or flight, and it's the body contracting and responding to the airway shutting down. It may not be sleep apnea, but usually you just say it's sleep disorder breathing until you prove otherwise, but it's the body's response to stress, the stress from breathing that triggers all these things, the clenching, the grinding, and so forth. But it can be related to all that too. So most of the time you see, like if the tonsils are big, they're going to grind their teeth, they're going to clench, maybe they're starting tongue tie. So you mentioned the high palate earlier. Airway dysfunction boils down to a space problem, and so it's just where can you make the space bigger? Is it inside the nose? Is it in the mouth? Is it the tongue space? Is it behind the tongue? And so it's just looking and trying to figure out where in the space is it constricted, obstructed? Where's the choke point? How do we make it bigger? Could be the palate, it could be in the nose. They talk about there's a higher incidence with tongue ties to have the smaller palates. It's been validated by research, and you can take measurements that the orthodontists know, between your molars, between your canines, and try to figure out like where you're at you don't always have to treat to a number. Like everybody'd be great if you had these 40, 42 millimeter palates, but you know, someone could be functional, you know, elsewhere. So it's identifying and knowing the norms in a way and try to, you know, how do we help get back. But, you know, the thing that most people are getting at now, and if say, like, if this is a kid, that's one thing, but that's an adult that has a palate like that, the reason the nasal breathing is so hard, and the reason there's so much resistance to airflow, and the resistance to airflow in the nose actually collapses the airway behind the tongue, that it's the same bone that makes up the upper jaw or the roof of the mouth is the inside of the nose. So that's why that Dr. Humano had research that shows you expand the palate on a kid, a palate expander on a kid is a cure for pediatric sleep apnea. You take an adult though, and you try to figure out, okay, well, how do you move teeth? Can you move teeth? Is it just skeletal? Can we, you know, so is it dental or is it a skeletal thing? And that's why more people are getting into true skeletal expansion, MSEs, surgical expansion on adults. The only way to get it on an adult is really actually trying to expand the bone with that. The kids are much easier, but with adults it's always a little bit more tricky, but it all boils down to that. There's, yeah.
So I just wanted to hit a point from my own personal experience, and I've read a lot in the dental research that, you know, you get a child that, you know, grinds their teeth while they're sleeping and stuff like that, but oftentimes it's an airway issue. One of my sons grinded his teeth since he was 6 months old, and at 3 we took out his adenoids and tonsils, and his grinding stopped immediately. So for a lot of therapists, you know, that's a real easy kind of trigger to take. But that's,
it is like
that's just soft tissue, but he'll
yeah.
probably need a palatal expander when he gets older.
Still, I mean, still did early, but that's the thing. Like my nephew was what 4 or 5 the other night, and I tried to get my sister to do it forever, and she did not want to have it here. Like when it comes from me, right? Like she won't listen. But then she finally got it done, and like she's like saying like, "Oh my, what am I doing? You're gonna make me kill him or something, or whatever." But then like the next day she called me like in tears, like, "I should have done this years ago. I should have listened." A completely different kid in one night's sleep. Completely different. She said, like in photos, it's crazy, but it happens so fast because you took away the obstruction with that. But so, you know, we talk about how do we diagnose, especially like this is a little more dental, but you know, it's looking at, it's not just teeth, it's not just making teeth straight, it's not just fixing the broken tooth, whatever it may be, but it's looking at the whole thing, the whole person. You know, so if you take, especially the kids, if you put all those things in the right spot first, and then figure out where the teeth need to be to keep in harmony with all that stuff. You know, so this is where you can get your therapist involved. You can take a kid, they come in, okay, we can identify maybe something's there. This is where I rely on someone like Jana to actually spend the time with the kid, watching them chew, watching them speak, watching them swallow, watching them breathe, and do all those things, and then show that there, you know, is an issue and things. And it's a great way to get the parents on board too. You may talk about, well, there's a tongue time, like, oh, what's that? Like, we'll go see the therapist, like, we'll identify and, you know, figure those things out. But then it just kind of leads to, you know, down the right path. So there are a lot of different things that, you know, we can look at that can be signs of distress or red flags that every therapist can start to layer in. And Jan hit on most of all this. This is a great form. She already touched on this. Measurements that are more like dental. But this, like, you can just go to ferris.org, you know, and any therapist can look at this very fast. You know, and it's research validated that, you know, the higher you have, like if you're 6 to 6, there's a high incidence of an airway issue. And so it's a quick screening, just looking at, you know, is something going on? If it is, okay, start the conversation. Where should the conversation go next? Jane already touched on that. But this is the thing, right? It's always, the tongue needs to lift, the whole tongue needs to lift, and the tongue needs to cup on the sides, especially for the babies nursing and feeding. It's not just the baby's gaining weight and the tongue sticks out. That's outdated research. This is where all that's at now, is lifting and elevation and trying to, how do we get the tongue to go there? And you mentioned like the R sounds and things, the back of the tongue needs to lift, but not only does it need to lift, but it needs the space in the mouth to make the sound. So that's your tongue space. So I mean, some of these things are, you know, real quick. That was the old thing, can the tongue stick out? And that's just measuring from there to there. And you can see long ones, but they can still be, that number can be greater than 16, but still have a lot of issues. But all that, just quick things. The compensation will be, is the floor of the mouth lifting? Is the jaw strained? Are they going like that when they lift up? An easy way for anybody to tell is it a because you can be confused. The tongue looks like it looks great, and it looks totally fine. Take your finger, put it on the floor of the mouth, hold the floor of the mouth down so it doesn't lift up, and then see where the tongue goes. Usually it lifts like this. And they're like, oh my God, it hurts. They have the tension. And you know, so like, and that's the whole grading scale is, the whole grading scale on this, it's all with compensations. Yeah. So it's taking that into account.
So like say a kid comes into our practice, I'm a dental hygienist, and what are like 3 things that we should look at, just like 3 things that we should be like, you probably should go see someone.
I mean, you can just have them lift the tongue up
Just
and
that.
start to see. I mean, it starts like just looking at tongue ties. You can do that, like do they wearing the teeth, just how are the teeth fitting together. It depends on age.
Is it true about like using their mouth and their cheeks and everything to swallow and not just?
You can ask them to swallow, and you can see, do they just swallow calm and gently? Does it look like that they're having to use their tongue and cheeks, like you're saying, like that reverse swallow and that and stuff? I mean, that would be all stuff like Jana would do and that. But I mean, I would just, when I look at just how are the teeth fitting together, can the tongue lift up? I mean, what do the teeth look like? You can just really look at the face.
Dr. Harriet, it's
Yeah.
6:45.
Okay, all right. So when you identify things, just before you take mass, we've already done most of these things, but you know, one big thing is if you're thinking about ties and where to go, it's, especially with kids, is there space for the tongue? Like should they see the orthodontist and have expansion first? Or should you do the tongue tie first? You know, or can you do the tongue tie first and then your expansion, like where does it go? So just trying to figure out what's the best step, since everything's going to be multiple steps with it. With the myo, like the way it typically, you know, works and kind of what I find, and you know, it may be different with each kid based off what's going on, but it could be like a month of the myo before release, maybe a month after. If speech is involved, you may have a little bit more. Babies can do body work. Older, kids and adults, if they want to do body work, they can. It's not a requirement, but you can layer it into it. But it just shows that the research shows if you do the myofunctional therapy before and after a tongue tie release, it's very successful. You're training the tongue as a muscle. The tongue is a muscle to give you muscle memory, to strengthen, to tone, to lift. So that way when you release it, it already knows what to do. It'll start lifting on its own. There's less bleeding. It's an easier procedure. You can watch how the tongue moves during the procedure, so it's more successful. And I find it's more comfortable for them afterwards because the tongue's already getting strong. Myofunctional therapy, shows over 50%, 60% reduction in sleep apnea symptoms by just doing myo. So it's not always myo for just tongue tie. You can do myo for any one of these things. If someone can't use a CPAP for sleep apnea, they can do myo to teach the tongue to lift up. You can do it for TMJ, speech, eating, chewing, swallowing. The habit cessation, I think, is the biggest thing. And it's one of the most important things to help with. So there's so many other, variables and benefits of doing it versus just always thinking tongue or tongue tie. So I like to look at if we do tongue ties, like you can do, like the babies, always the wound open. For nectomy, you're just releasing the tissue. If you have a little canker sore wound, you can do the frenuloplasty now is where Dr. Zagi's taking it, is you do the therapy first, you teach them to lift the tongue, hold the tongue, and move it. During the procedure, you're actually watching it. So you're saying you're actually releasing the tension at the same time. So they call it frenuloplasty, like you're changing it. But that's the way to go. It's always more successful. The wound is much smaller. It's much easier. You can do them under sedation, but we just say it's a sedative frenectomy because you can't watch the tongue move. You still do myo before and after, just a little different. With that anterior, posterior tongue tie, with that, the way I like to look at it, when I first learned it, it's confusing. I guess like in the back of the mouth, it's all in the same spot. It's just that the posterior tongue tie means it's limiting the movement of the back of the tongue. The tip may look like it moves, the back can't lift with that. So after release, the whole tongue's lifting, not just the tip of the tongue. Those are easy to spot. Posterior ties on, babies are harder to spot. Usually I look to the mouth, it's mild, there's not an issue. You don't diagnose on appearance unless you see that. All other ones, it's more based off of function and dysfunction.
I just want to say, the back of the tongue, if you have a kiddo come into your practice and they are over the age of 6 and they don't have their R, they need to have R mastered by 6. And the base of the tongue needs to be lift up for correct production of the R. And the sides of the tongue in the back need to make contact with the back upper molars. And if they're restricted back there, we will work and work and work on getting that tongue up and back. And those kids struggle they struggle and they're in speech therapy for 4 and 5 years and they still don't have their R. So if you're hearing them talking and they say they don't have the ah, and they're 6, 7, 8, 9, 10, then tongue tie is definitely something to look at.
Yeah. So, I mean, it's, can't do it personal, but obviously there's no such thing as a mild tongue tie. If it's causing a problem, it's causing a problem. There's no grading scale that's mild, moderate, severe. It's all based off anatomy. So if it's an issue, it's an issue. Just deal with it. Open versus sutures. I like to put sutures in anytime you can, babies you can, but that's the biggest variable. Older kids and adults, the healing's so much better because the sutures, it heals on its own. Then you do your therapy, you teach the tongue to work afterwards. When the wound's open, there's so many more variables. So why it's like, oh, the tension's coming back. Well, it's hard to do stretches. Parents hate it. Kids are crying. They have teeth. What's going on? A lot of different things that can play a role into it. So that's why I always think like it's always more predictable in older kids and adults. So that's why some babies may have it once, but they may need it again later in life because you can only do so much safely in one visit. Anytime it goes to the tip of the tongue, any age, tell everybody it could be a 2-step release. Maybe one now to get you going, but it could be a second one years down the road if something else is going on. You can safely only do so much. If they got it clipped in the hospital, it may be enough, but you cannot go deep enough with scissors. It has to be a laser to get it down safely with that. The other thing with kids, especially 1 to like 4 or 5, involvement is a must. You won't do it unless the parents are on board with that because it's so difficult. Like I talk parents out of doing them at that age. Like you have to be on board with that because it's so hard to get the hands in the mouth. The kids are fighting you, they're biting down. With that, results can be so variable with that. Otherwise, when you do your therapy beforehand, that's the wonderful thing though. If you work with someone like Janet that teaches, a lot of the pre-work before is just teaching the parents how to do the stretches and getting the kids used to hands in the mouth. So much more successful. The kids just lay there, they let you do whatever. Like the hands go in and not during the release as much, but for the stretches and the therapy, and I find it's so much easier and less traumatic for parents and kids. So parental involvement is a must. This is mine. Dr. Zagi did mine when I was doing training with him. I was the one who couldn't say rabbit as a kid. I could not say an R sound. I did speech and I got better, but then in hindsight and stuff, I kind of just wanted to experience it. And come to find out, mine was very big and very deep and it hurt like crazy. But yeah, so it's just my healing all through mine. Lip ties and stuff, there's some more obvious just to kind of look at. Usually babies and stuff, they definitely play a role enough to get into it. We can just go into some of those cases, Jana. I'll not do as much with these.
Yeah,
But I'll just do a couple real quick, just like looking at faces. With that, I mean, you see a face, you look in the mouth, and you see this on, what, a 9-year-old? You know something's going on. You see a face like this, something's going on. That's one round of the palate expander and look at the face. With that, you look at the eyes, the symmetry, how everything is, happy, sleeping, breathing. You see kids with cross bites and look what it does to the body and posture and all that. It all starts with the joints and the teeth. And you look at these faces, but then you take a look at the face and you look in the mouth, and they always amazing. I mean, you can tell a lot of issues with some of that. So just collaboration, talking points. Janet's already touched on some of these, but I think you asked about like how long to nurse, like those things that, there are things that I say, sometimes it's trying to like coach and just help guide, parents and things that we're living in the modern world, right? It's moderation. Not everything can be perfect along the line. So you do the best you can. It's always like, well, I ate an organic diet and I had a release when I was younger. Why do I still need expansion? It's multifactorial and stuff. Don't beat yourself up. Things will happen. It's in our DNA now. We just deal with it and move on. But there are things that you can just be aware of and start to point out with that. But the biggest thing is just be aware, have your eyes open, diagnose, treat early. You treat early, it's way easier. I see. I can bring yours up.
Oh,
Yeah. That's it. Oh, like you guys all know these with therapists and stuff. There's so many little things you can give the kids and stuff. Let them start chewing.
Chew, chew, chew.
Chew. Whatnot, but it helps.
Scarlett.
I'm working hard.
Excellent.
So, we're gonna probably, what time is it?
It's like 5 minutes.
Okay,
We
we're
got
gonna
5
probably
minutes.
just have time, and then if anyone wants to stay after to talk to Dr. Perry, definitely. We're gonna show you a patient, actually that had, we've been
Since my
working.
computer's up, we'll show it real quick.
Oh, yeah,
I'll
is
show
that
you,
him?
I'll show the pictures.
Absolutely.
Then you can show yourself.
Okay, yeah,
This
there
is
you
mine
go.
hooked up.
This is my patient that went over this morning and had his frenectomy. Yeah.
Oh,
He had a posterior tongue tie,
yeah.
speech deviation, speech R, open mouth breathing, posture at rest, 9-year-old, and frustrated that he can't say his R sound, really is what they came in with open mouth breathing. His mom said he always has his mouth open, can never get him to close his mouth. So I did the myofunctional evaluation. He clearly had a posterior tongue tie. He's been working with me for 1 month on pre-myo work, pre-frenectomy work. He could not sustain any kind of lingual hollow suction when we started, not even close. After 4 weeks of therapy, I got him ready, and then he went today for his frenectomy.
You do so
Or
good. That,
cranioplasty.
yeah, that's the thing is the suction hold.
Mhm.
Just lifting up. They can hold that for 60 seconds and train them. It's so much better. So that's the whole therapy. He's doing it and showing it.
Mhm.
Stuff he's strong, but
This is pre.
still the floor of the mouth lift. But
And you see the Eiffel Tower here? We look at this Eiffel Tower here. An Eiffel Tower on suction is another red flag for tongue tie. So if you have an Eiffel Tower, everyone afterwards stay tight and look at Kim's Eiffel Tower. She's got a really nice one.
I got an
But anyway,
Eiffel
you see
Tower.
how it's attaching at the gingiva here behind the teeth? That is a restriction, okay? And that is causing that craniofacial valve. I'll show you his pictures in a minute, but his whole craniofacial valve, and you can tell.
that'd be the one if he held the salivary gland down.
Yeah,
wouldn't
he would
hit his
never be
mouth
able
at
to.
all.
Yeah.
It's not at all. We did a lip release too, but that's his labial frontal. This one, the first time I've ever had this happen though, I injected to numb it and it caused like a little human. So I thought it was beginning to like start bleeding like crazy. I said open into it, but we bypassed it. Sorry, they're sideways, but some releases it's just tissue. Those are like pretty simple ones. Some there's a little muscle. Some it's all muscle put into it. He was kind of in the middle. A lot of tissue, just some muscle. If it's a lot of muscle like mine was, it's much more sore afterwards. But there's the tongue after. There's the left now. There's no floor of the mouth, no compensation at all now. But that, so it's just a little bit. There it is.
Did you do this under sedation?
No,
No, it's under local.
yeah. Just infiltrate right under the tongue. And all that.
And he's got
Yeah.
an amazing,
He's so
about
good. He's
50,
nice.
50-inch TV that they watch Nemo or something.
Yeah.
They get distracted, so.
Put on Rookie of the Year.
Or something,
The
you
old
know,
days,
KU
old
game
days.
or something, they're like. Go ahead, I'll just watch the KU game.
It's amazing.
What is the best? What's the best anesthetic to start taking?
And I'll just show you real quick when he came to me,
It is crazy to think about that.
see that. How do I pull that up? How do I get my
IT support. Oh my God, dental stuff. You're gonna have to speech
So this is an example of my myofunctional evaluations. Everyone's will look different, obviously, every therapist is different. But, and this is him on stage because this wasn't his normal rest posture when I took it. I was like, just natural, and he was like, you know, he wouldn't do it for the picture. But, yes, here he is here. Obviously, you know, I diagnosed him with an oral dysphagia, which is tongue thrust. And an articulation disorder because he does not have his R sound due to a posterior sublingual tongue tie. You know, I'm recommending frenectomy, cranioplasty, with myofunctional therapy and speech therapy to correct his R sound, absolutely. And so we actually, you know, we do a developmental evaluation. We look at the oral structure. I'm looking at it from what kind of, you know, he had an anterior overbite, class 1 molar occlusions, splayed upper central incisors with diastema. Currently has 2 tongue guards on the back of the anterior incisors to help with thrusting. I measured him at 50 millimeters width on palate, but I do believe he's a little bit more narrow than that, I'm not sure. And so here's his tongue tie assessment, Zagi. He rated out of 3 with me with compensations with the floor of the mouth and a 4 I got him to 2 teeth and was unable to choose, that should be, I think it's 4. He was unable to choose, get any kind of full compensations or full lingual pallisection. And so we kind of go down, we look at lingual function, the mandible, the facial structure, just really full lips, placidity with the buccinators and masseter muscles. So we really want to kind of beef those up. So he just has a little bit more of a kind of chiseled look. Cotlow class 3 lip tie. So we got that released. He was an open and closed mouth breather, but he was able to sustain his mouth breathing on command. So he could breathe through his nose very well. He watched a great video for me and he did well. So I wasn't really concerned about tonsils and adenoids. Palatine tonsils were a 1. His oral French opening was Malocclusion class 1. I mean, great airway. And then his swallow assessment, his tongue thrust. So here we go, and then we did some articulation, and then we have a photo addendum here. He's a cutie, and there's his photo addendum there, pre-productomy. And you can see here this asymmetry. See that tongue coming out? Coming out, lots of restriction there. He has a great tongue taco. Some of our restrictions can't do a tongue taco. It kind of just,
That's hard to do.
it is. It just depends on where and where the tongue is restricted. You know.
It's genetic.
The time? Yeah.
What's your thought on the tongue taco being genetic?
Oh, I could be, for sure.
I have my thoughts on that.
I
thought that is common knowledge, no?
With the tongue trying to roll?
No, this.
Tongue taco.
This
Who
is
can
my
do it,
thought,
Nick?
Justin.
I've heard that, I can
People think
see
it's
that,
genetic because I do believe, this is my thought, and this is just Jana Wallen, I don't know. But I believe tongue ties are definitely familial. We
Yeah.
know that they typically fall down from the paternal side.
Yeah.
So we know strict tendon tissues is genetic. I think that's where the genetic comes, because 9 times out of 10, I'll be working with a kiddo or a patient and their parents were like, well, my husband has a tongue tie, or I have a tongue tie. So I think that's where the genetic component comes in a little bit. I think, that's what I think.
What do you mean, is it, sorry, I don't understand what you're
Were
saying.
you looking at your phone?
I'm sitting.
Yeah. So, I was saying that I think it's genetic. People think it's genetic because typically if they have a tongue tie, someone in their family also has restricted tissue somewhere. And maybe their mom can't do it, you know. I don't know.
There's an
And I guess that's genetic, I guess, in a way.
But are you saying that if you can't do a tongue taco, that's not a genetic thing, it's a mobility, like strength thing? Is that what you're saying?
I think it's a tissue restriction.
It's genetic.
Justin can't do it.
Okay, well,
I could, there's no way I can do that.
I can pour one
because
too.
you had a posterior tongue
I'm
tie.
hard to still. Really?
Oh, still.
Can you do that? Can you roll tongue?